Good afternoon, ladies and gentlemen. And first of all, I want to say the words of great appreciation for the invitation. And before I'll start my presentation, I want to say the words of congratulations to Japanese scientists for the Nobel Prize Award to the Japanese biologist Yoshinori Osumi, if I'm right in pronunciation. And the importance of the cell reaction to starvation, to infection, and to radiation is absolutely proved. And we'll speak about a very sad situation which is in Ukraine now, because this April we had the 30th anniversary after the Chernobyl tragedy. And it was a time to make some conclusions and evaluations. First of all, after the very beginning of the assistance for people who were evacuated from the zone of the accident, and especially for our female and children cohort, we understood that we have to start the special registry. And this register for the data collection now accounts more than 20,000 persons. And this register is created by people who were evacuated from the zone of the Chernobyl accidents, from residents of regions controlled by the level of radiation, who were exposed to radiation in childhood and adolescence, and for this time passed through the 1986, we have a new cohort, women who were exposed to radiation in utero. I suppose that our previous lecturers talk about the possible health effects of radiation to the organism of the human being, especially for female and children. And we have to say that all type of radiation were after the Chernobyl accident, and they affected all the possible system of organs of female and children organisms. And since the very beginning of the assistance for these cohorts, we thought about such consequences like thyroid cancer, solid tumors, and leukemia, of course. Acute phase, it was the most dangerous period in 1986. We have to evacuate a lot number of people from the zone of the accident. And in that zone, at that time, were 533 pregnant women. Some of them were in the pregnancy period before 12 weeks, and they were suggested to terminate the pregnancy, and the pregnancy in some of them was interrupted. But the majority of women were in the second and third trimester of the pregnancy, and they delivered in the Institute of Obstetrics, Pediatrics and Gynecology, and obtained all the assistance during all the periods up to 18 years old of their children. And just now, it would be at our slides, we have a special cohort from these children, and I suppose that we have to continue the investigation and observation of these cohort. Evacuated women, what were their complications of pregnancy and deliveries? First of all, it was the threatened miscarriage. And nearly 80% of women evacuated suffered from this. The rate of the prematurity is 36%. The average incidence of prematurity in Ukraine is now lower than 5%. So it is about 8-fold increase. Anemia, 80%, fetal distress during the delivery, 44%, pyelonephritis, 40%. And during the first 3 months after the evacuation, the delivery and postpartum period was complicated by increased blood loss, obstructive labor, fetal distress, and in this cohort, it was a tendency to the increase of postpartum inflammatory complications. We are speaking about the estimated cancer risk. And at that time, for the solid cancers, it was considered the estimated cancer risk as 4%. For those women who undergo radiation exposure in childhood. For breast cancer, it's about 6%, and risk of thyroid cancer is about 70% in women who have undergone radiation in childhood. If we take into the consideration that in women, the average expected risk of thyroid cancer is about 0.75 for their lifetime, the increase of 70% is huge. But at that time, based on the experience achieved by the A-bombing and previous accidents at the nuclear power plants, our oncologists and endocrinologists told us that the first thyroid cancer could be in 10-15 years after the Chernobyl accident. And the first thyroid cancer in the childhood and adolescent age was in 1989, so in 3 years after their accident. And after the studies of the cancer, thyroid cancer in Ukraine, our oncologists told us that we have to meet 3 earliest. Thyroid cancer after Chernobyl, first of all, is early to appear. The second is in early age. And the third, early to metastase. Because the previous studies for the thyroid cancer told us that the thyroid tumor, malignant tumor, does not metastate too early and too spready, but the Chernobyl variant of the thyroid cancer did. There is data concerning the pregnancy and delivery disorders in women who are the inhabitants of regions controlled by radiation. And you can see that there were, I'm sorry. I'm sorry. A very low percentage of such complications before the accident. And you can see the first is hypertension disorders arising, moreover arising the obstructed labor and obstetric hemorrhages. And on all the zones are controlled by the radiation, all the maternity institutions were prepared and ready to give the special assistance for such the complications. This is very interesting studies which were performed with the multidisciplinary approach of the Institute of Pediatrics, Obstetrics and Gynecology and Saitama University, Professor Nobuo Takeichi. And we studied the placentas from women exposed to radiation. And the special attention was paid to the placentas of women who suffered from the thyroid cancer. It was studied the cancer embryonic antigen, PCNA, vessel endothelial growth factor, and the level of the apoptosis. And of course, there was the evaluation of the radionuclide presentation in the placenta. And our morphologists studied the cesium and alpha radionuclides incorporation in placenta of the organisms of the stillbirths, of the abortion fetuses, and in their placenta. And you can see the presence of the cesium and alpha radionuclides in teeth, in thymus, in brain, in placenta, in ribos, in spine, and liver, and in the spleen of those fetuses and stillborn fetuses. And it was clear that placenta is not the barrier for the cesium and alpha radionuclides. Although our morphologists studied the proliferation reactions independence of the radionuclides incorporation. And you see that the most expressed proliferation reactions were these in situ trophoblasts. The second is fibroblasts and the in situ trophoblast. And after the gathering all this data from the placentas of the children who were exposed to radiation, and it was created the so-called passport of the placenta, and the children in placenta of mothers who had the most expressed proliferation reactions, this information was given to their pediatricians in order to follow up the children. And on this slide, you can see also the dynamics of radionuclides placental incorporation in women living the in contaminated area. And this study occurred to 1997, and this study showed the increase of the placental incorporation of cesium and alpha radionuclides. The most vulnerable question is about the genetics and possible mutations after the Chernobyl nuclear power plant accident. And these studies were performed with the multidisciplinary approach with our French colleagues, especially Professor Ingrid Emmerich. And it was shown that the level of mutations were in their children born from the cleanup workers when the conception occurred within the cleanup works of their fathers. You see, but if conception occurs after the end of the cleanup works, it was not so significant. So the genetic studies have to be continued in our country, and now, as far as I know, that the cohort of the children who were conceived during the cleanup works of their parents is continued in the Institute of the Radiation Medicine in our country. Thyroid cancer. Of course, we met the situation when the thyroid cancer occurred in our women who were in the childhood and adolescent age. And it was the largest cohort in the world. No experience for such a great number of people who suffered from the thyroid cancer and what to do with their pregnancy. And it was our work. I was involved to this work since 1998. And it was the comprehensive survey on women within the dynamics of their pregnancy. What we met, the threatened abortion, 86%, it's very significantly great incidence. Threatened prematurity, 25%, and hypertensive gestational disorders, 18%. But not only the thyroid cancer, for which the woman was diagnosed, operated, and obtained the special treatment before she became pregnant. We find out that the number of women who were diagnosed with the thyroid cancer during pregnancy arose. And we had to create a system for perinatal care for such women, because you can see that the complications of pregnancy are also high. The threatened abortion is 55.2%, and the threat of the prematurity is under 20%. What kinds of the complications and the disorders have been revealed in those women during pregnancy? First of all, the disorders of phosphorocalcium metabolism. And it was 5 times more likely than in the physiological gestation. And the first target for this cohort was to establish the presence of the thyroid homeostasis disorders and to create the conditions of the satisfactory, to create the condition to make the pregnancy period for this child and future newborn to be physiological. And we established the proper time of the surgery for thyroid cancer. It's about the second trimester, 15th, 19th weeks, with the adequate hormone replacement therapy. And all this allowed us to reduce the percentage of prematurity and to prevent the birth of the small for gestational age weight children, and to deliver children with higher Apgar scores at birth, and comparison with the data of women who were operated in the later stages of pregnancy. This is the algorithm for such pregnant women to perform the thyroidectomy at the 18-20 weeks, gestational weeks, with the adequate progesterone supplementation, to start the levothyroxine supplement replacement therapy, to keep the TSH lower than 0.1, to establish the adequate iodine supplementation, about 20 micrograms per day, and taking into consideration that all the cancer patients are likely to have the hemorrhage during the third stage of the delivery, we proposed the active management of the third period in labor. And what about the delivery management? For this cohort of patients, we were ready for the obstructive labor. because to the strict connection between thyroid disorders and disorders of the endocrine metabolism in the fetal placental unit. There was no indication for the elective cesarean section, but obstetrics, I have to explain. During the first years of the thyroid surgery in Ukraine, it was high incidence of the recurrent nerves lesions after the surgery. And our surgeons proposed us to perform the cesarean section in order to avoid the complications of these lesions. But during the last 20 years, due to the changing in the performing of the thyroid surgery, we never met such the lesions of the recurrent nerves. And so now we perform the cesarean sections only by the obstetrics indication. And we were ready for the excessive blood loss. And when we established and implemented such comprehensive perinatal care for this cohort of women, our perinatal outcomes were encouraging. No cases of perinatal mortality or severe perinatal morbidity, no congenital hypothyroidism, no congenital defects in cohort of newborns from mothers with thyroid cancer, no perinatal losses, and all the pregnant who exceeded the 12 gestational weeks period delivered in full term. Their prematurity was 8.9%, and as I told that the level incidence, the average incidence of prematurity in Ukraine is less than 5%. But we have to pay great attention to the psychology disorders in this group. This group is very affected by their diagnosis. They have cancer and they have the uncertainty about the consequences for them and for their children. And we have the special perinatal psychologist who works with this cohort of women. And the perinatal psychologist revealed that this group of women has significant negative changes in the psycho-emotional sphere. First of all, it's a high level of personal and reactive anxiety. And it were established a special methods, the psychology prophylactic methods in such women, and this approach allowed to enhance the adaptability, to increase the neuropsychological stability, and to increase the personal and social activity of these women. They were encouraged in the results of their pregnancy, and the results could be explained due to this approach. We spoke about exposed in utero. And all the children born within the period from 27th of April 1986 to February 1987 are included in this cohort. And as you can see, the obstetric disorders in this group exposed in utero also includes the first and the most significant is the threatened abortion. It's 42.7%, but it's much more higher than in the average population, which doesn't exceed 12%. Morning sickness, preeclampsia. Preeclampsia, hypertensive disorders have the great impact for the future life of such women. Intrauterine growth restriction, it's 19%. There is no percent in the control group in this cohort of women. Placental dysfunction and fetal distress are connected with each other. And what was their conclusion? That the smaller the gestational age of mother occurred at the time of the accident, the more substantial violations observed during the formation of the placenta, affecting the health of their offspring. And this issue requires further research, in particular the incorporated radionuclides in the placenta of 30 years after the Chernobyl accident. We have to speak about the lessons. The first is, if we have an accident at the nuclear power plant, we have to listen to the truth. And what was never done after the Chernobyl nuclear power plant, which had, this fact had a great impact on the further health state of our females and children. No adequate iodine prophylactics in 1986. No adequate evacuation. Compare the evacuation from Fukushima and evacuation from Chernobyl. Open arms, open heads. And the most great mistakes of the Soviet Communist Party. This is the 1st of May in 1986. Nobody evacuated and nobody was told to go from the open air. Thyroid cancer. We have to introduce such women, not the medical abortion, but the preconception counseling, which demands to avoid the hyperfunction of the thyroid gland, avoid the anemia, avoid the fear of cancer, and avoid the unnecessary laboratory investigations. Thyroid cancer during pregnancy, triple verification, evaluation of the situation by multidisciplinary approach, and decision-making. Just now we are speaking about the possibility to postpone the surgery in the postnatal period, and it would improve the results of the pregnancy. The necessity of the radioiodine therapy, we speak with our endocrinologists and oncologists for each the case of the thyroid cancer during pregnancy, and what is the best period for this. The negative influence of radiation exposure for women and children, female reproductive disorders, increase of obstetrics and fetal disorders in all the cohorts of the radiation groups, decrease of healthy children cohorts since birth and in different age periods in all the control zones, increase of morbidity in children in cohorts of radiation control. What we have to continue? We have to study the exposed in utero, their somatic, mental, and reproductive health issues. We have to continue genetic factors in second generation of the offspring from parents, cleanup workers. And we have to develop the register for children and women exposed to radiation, somatic, and reproductive health state. Thank you for your attention.